Hi, my name's Jacqueline Hayter. I'm a registered respiratory therapist and neonatal pediatric specialist, and I'm also the lead pulmonary educator with Aventa. Today we're going to be going through humidified high flow therapy or high velocity nasal insufflation. So during this module, our goals are going to be why high flow candidates, clinical benefits of humidified high flow therapy, high flow which decreases opportunity for infection, benefits of 100% relative humidity, multiple interfaces for the devices, as well as the benefits to traditional cool mist aerosol. Why high flow? So the definition of high flow is oxygen systems that can supply a given O2 concentration at a flow equaling or exceeding the patient's peak inspiratory flow. And it allows for a fixed FiO2 that can be adjusted. It's utilized to support members' oxygenation and ventilation. The FiO2 and flow can be titrated independently to best suit the individual patient's needs. There's multiple interfaces for a variety of patients. There's a variety of devices, and there's also numerous clinical and quality of life benefits, including various units allowing for out-of-bed activity. Going through the definition of high flow, and this comes from the Respiratory Bible itself, Egan's from Kasmeric. And what this is pretty much saying is that your patients and all of us, we have a need, we have a peak inspiratory flow that we naturally have. So when we're in respiratory distress, we're trying to get more and more flow in. It's like we can't get it in fast enough. So what high flow does is it meets that demand or it exceeds it. So it allows your patient to take a breath, be able to rest their respiratory muscles and prevent fatigue. And another benefit is that it allows for a fixed FiO2 that can be adjusted, as opposed to, say, your binasal cannulas, which are dependent on your patient's respiratory rate and how they're breathing. It can also be utilized to support your members' oxygenation and their ventilation. So oxygenation is, of course, talking about how well your patient's oxygen delivery is occurring. Is it able to pass through the alveoli and oxygenate that blood and be carried out throughout the tissues? And by ventilation, we're talking about the CO2. How well are they blowing out that CO2 so they're not retaining it and it's taking up that space where oxygen could be instead? The good thing about high flow is that the FiO2 and the flow can be titrated independently to suit your patient's needs. Not every patient is going to progress or regress the same way, and each patient is going to have different needs at different times and certain vitals or goals that we're trying to help them reach. So for instance, if you have a patient who is sitting at, say, 80% at 45% FiO2, but they're still breathing a little bit hard, but they're definitely progressing from where they are. We can independently change their FiO2 without having to adjust their flow so that we can keep on weaning their flow but meeting their oxygenation needs. And vice versa. If we have a patient who is sitting beautifully at 98% while at 30% FiO2, but they're chugging like a freight train and you're worried that they're going to tire out, we can adjust their flow independently and up it without having to worry about their FiO2 or over-oxygenating, which is especially important for our neonatal patients and our COPD patients. There's also multiple interfaces for a variety of patients. It's not only non-invasive and it's not only invasive. It can be used for both. For non-invasive, you have your nasal cannula, and for your invasive patients, you have trach collars, and you also have a direct connect interface that you can use. There's a variety of devices to best suit your facility as well as for your patient or whatever setting that they're going to be transitioning into. And there's also numerous clinical and quality of life benefits. We'll get into more in depth about what clinical benefits there are, but one of the best quality of life benefits is that a lot of these units can be transported, which means they can get out of bed, they can participate in activities, they can do therapies, and it's going to help their mind, and it's also going to help strengthen those respiratory muscles and help shake those secretions loose so that they can expectorate them and hopefully get off of the high flow, or at least see what their baseline is on the high flow if it is a long-term solution. Now let's go through high velocity nasal insufflation. It increases velocity of gas by increasing pressure. Small bore tubing and small bore cannula openings allow for higher velocity of gases. It decreases dead space, and it increases your alveolar ventilation. It also provides a natural reservoir. And it's less susceptible to cooling and rainout. For high velocity insufflation, you could say that it is a type of high flow because it is doing the same job as high flow. We're still meeting or exceeding our patients' inspiratory demands, but the modality of it is just a little bit different. So with these devices, to provide this high velocity delivery of gases, it's going to be using a lot smaller of a diameter in their tubing. So as opposed to, say, your typical high flow circuits that's shown on that top right corner in the blue, that's your typical high flow heated circuit that you run into. And you can see that it's a whole lot bigger. The diameter's a whole lot bigger than the one on the bottom, which is the type of circuit that's used for your high velocity nasal insufflation. So because the diameter is so much smaller, the gas is going to have to push through faster in order to get to where it needs to go. And then that bottom diagram in that same image shows just how as it narrows, it goes faster because it has to be going through a tighter space and it has to go in. So it's going to go faster, and so it's going to be delivered to your patient faster than with a larger bore tubing with your heated wire. In conjunction with that, the cannulas themselves for high velocity nasal insufflation have a whole lot smaller opening than your typical high flow nasal cannula. Your high flow nasal cannulas are designed to be bigger to create more of a seal in the nares. And so that's going to be creating the pressure. Whereas with high velocity nasal insufflation, the goal is to deliver it so fast that it's washing out the dead space so that it's meeting your patient's needs. And by decreasing the dead space, we're going to increase the alveolar ventilation. If there's not as much CO2 that's building up in our anatomical dead space, then it's going to allow for more oxygen to go in and participate in gas exchange because there's not as much CO2 taking up that space. The other good thing about the high velocity nasal insufflation is that it provides a natural reservoir. The gas is being delivered at such a fast rate that it's going into your members or your patient's nares at a very high pace, faster than they can exhale it. So it's building up in their airways, so it's always there. Even when they exhale, there's more coming in to replenish it. And it's also less susceptible to cooling and rainout. Again, it's going faster and the diameter of that circuit is smaller. So there's less opportunity for those humidified molecules to break apart and cause that water rain out in your circuit, which then can pose a risk for infection or aspiration. Now let's go through our high flow candidates. Patients with or without tracheostomies, compatible with trach collar, T-piece, and nasal cannulas, spontaneously breathing patients of all ages in need of extra support without requiring high levels of pressure, whether it be acute, chronic, or weaning, patients with copious amounts of thick, tenacious secretions, patients prone to respiratory infections, and tracheostomy patients with speaking valves. The great thing about high flow, as I mentioned before, is that it can be used with patients with or without tracheostomies. It's used for invasive as well as non-invasive patients. So you can use a typical traditional trach collar as shown in that top picture, one of those bigger, bulkier ones that you have to strap around and it sits right in front of the tracheostomy. You can also use it with a T-piece with a PEEP valve so that you can provide that little bit of extra pressure and progress your patients toward weaning. Or you can use it with your nasal cannulas. Of course, as it's commonly known, high flow nasal cannulas. But all of your patients, regardless of what interface you're using, have to be spontaneously breathing patients. Because the high flow, like your other oxygen devices, isn't providing a rate. It's providing pressure and it's providing flow, but it's not going to provide a rate to make sure that your patient is getting what they need. So if you're trying to wean a ventilator patient, but they're riding the ventilator constantly and they're not making any spontaneous efforts to take a breath, we may need to take a couple extra steps before bringing them to high flow. Because if you just put a high flow on them and they're not getting that rate and they're not used to it and their respiratory muscles are weak, then it's likely that they're not going to succeed. But the good thing about it is that it doesn't require high levels of pressure. So really in those times when we're either starting to go towards respiratory failure and we're more in the respiratory distress phase, or it can be used chronically for some of our patients, whether it be non-invasively with a nasal cannula or with our tracheostomy patients. It can be used for a long-term solution to make sure that they're still getting a little bit of extra pressure and humidification to keep them from contracting infections or developing respiratory distress. It's also useful for our weaning patients. So those patients where we've weaned them as much as we could from the ventilator and we're not really wanting to take them straight off the ventilator and letting them just be completely free of any support. It's that nice little stepping stone to make sure that when we liberate our patients that they're going to be successful. And then we can move towards weaning them from high flow if it's applicable. Another great candidate for high flow are those patients with copious amounts of thick, tenacious secretions. And we'll go into more detail about that when we talk about 100% relative humidity. But I will say that the good thing about it is that, again, remember, you can titrate your FiO2 aside from your flow. So even if your patient is doing great, that they don't have any oxygenation issues, but they're still needing a little extra support or they're still needing some humidification for that thick, tenacious secretions, we can still apply that high flow to manage their secretions without necessarily having to apply FiO2, but we can should they need it in the future. Patients prone to respiratory infections are another great high flow candidate. And the reason for that goes back towards the patients with thick, tenacious secretions. If we're getting patients that have a lot of occurrences for pneumonia, they're having to take antibiotics back to back, they are in and out of the hospital a lot for respiratory infections and pneumonia, and while they're in the hospital, they're getting all of these forms of secretion management. One of the things that we can utilize to help prevent that in the first place is going ahead and putting them on high flow to make sure that we are managing their secretions. And then also, it can be used with tracheostomy patients with speaking valves. And this is used with the idea of decannulation in mind. So they're able to have their speaking valves on, and they're also able to have that extra flow and humidification applied. You can either have the speaking valve in place or have the cap in place and then have the nasal cannula in to see how they would fare once decannulated. Or you can put the speaking valve in line or underneath the trach collar, depending on what kind of interface that you're using. So now let's get into the nitty-gritty, the clinical benefits of humidified high flow therapy. There's a reduction of dead space with clearance of expired CO2. It decreases rebreathing, clears airway of expired gas, and overall increase of alveolar ventilation. The reduction of dead space, and I mentioned this briefly before. So what high flow does is that it's providing so much more flow that it's able to blow out that extra CO2. And so they're not going to be rebreathing that CO2 that is getting caught in their anatomical dead space. So it's going to allow more oxygen to come in, and it's going to flood the airways with the FiO2 or room air, whatever it is that they're using, and allow for oxygenation to occur. And so if we're providing more oxygenation into our anatomical dead space to where it's not really as much dead space, that's going to overall increase our alveolar ventilation because there's more space in that alveoli for gas exchange to occur because there's not all that extra gas taking up those little great parts of our alveoli. There's going to be more opportunity for your oxygen to pass through that alveolar membrane into your blood for the tissues to be oxygenated. And likewise, there's space for the CO2 that your blood is delivering to pass over through that alveolar membrane back into the alveoli for it to be exhaled. And on this graph, you can see the effect of nasal high flow on the reduction of dead space and the clearance rate with a radioactive tracer in an airway model. So what this is that they used radioactive tracer in the airways, and they saw how quickly it was able to be reduced or able to be exhaled with, depending on the liter flow of the nasal high flow therapy. So you can see as the flow increases, the rate also increases because, again, we're adding more into the airways so that there's not as much of that extra left behind, and so it's being cleared out at a faster rate. The higher the flow, the higher the clearance. Our next clinical benefit of humidified high flow therapy is the dynamic positive airway pressure, which varies with the breath and flow. It provides 0.5 to 1 centimeter H2O per 10 liters per minute with a maximum of 6 centimeters of water. It promotes elongated exhalation and it increases alveolar ventilation. When we're talking about dynamic positive airway pressure, it's going to vary with how our patients are breathing, and it's going to vary with the flow. The faster that they're breathing, there's not as much pressure that's going to be applied. So when we increase the flow, we're increasing the pressure. And studies have shown that per 10 liters per minute on your high flow is going to give you about 1/2 to 1 of PEEP. So if you have a patient that's on 50 liters of high flow, that's 5 of PEEP, essentially. And so it's a really effective way to make sure that we're keeping those alveoli nice and open, even on the exhalation, which we know is what PEEP is made for, is to prevent that collapse of your alveoli. And so it's going to promote that oxygenation, and it's going to help decrease the work of breathing because they're not having to work as hard to reinflate those alveoli with each breath because they're already getting that bit of PEEP. And it's also effective for tracheostomy patients, especially if they have a direct connect trach collar in place. This is one of those interfaces, and we'll go through it in more depth, but it connects directly to the tracheostomy. And so they're getting all of that flow, and it allows for more of that pressure to be delivered without having to worry about, say, with CPAP, where it's just constant pressure that never lets up, that can often lead to mucus plugs and pneumonia. It's a little bit gentler, and again, it's going to vary because it's controlled, besides with the flow, also with how your patient is breathing. So they're still getting that extra bit of PEEP without having to worry about that constant pressure pushing those secretions back down and having risk for mucus plugs and pneumonia. And I've seen patients code because they've been on CPAP and they had these thick mucus plugs that they couldn't get up because they were on CPAP. Another thing about the dynamic positive airway pressure is that it's going to promote elongated exhalations. So this is especially important, say, with our COPD patients, for example. One of the things that we learn is that COPD patients take a long time to make a full exhalation because they're retaining all that CO2 and they have these hyperinflated lungs, and it's just so hard for them to get it all out. And even when they do, it might not be all of it. So with high flow, it's going to assist with that promoted elongated exhalation. And so by putting a little bit of pressure, it's going to take them longer to exhale, and more CO2 is going to come out because they're exhaling longer. And that is going back to increasing your alveolar ventilation because, again, you're decreasing that dead space. This graph to the right of this page compares and contrasts how airway pressure is changed along with inspiration and exhalation with high flow compared to your face mask oxygen. So you can see how much longer that exhalation phase is because they're having to breathe against that pressure, and it's also keeping those alveoli nice and open. All right, so recapping clinical benefits of humidified high flow. It provides respiratory support via reduction of dead space and applying dynamic positive airway pressure. Physiological outcomes include reduction in respiratory rate, decrease in work of breathing, decrease in CO2, and an increase in ventilation and gas exchange. So when we combine the benefits of high flow. We're reducing that dead space. That's going to help more oxygenation take place and making sure that our tissues are well oxygenated. And that dynamic positive airway pressure, it's making sure that we're able to keep our alveoli and our airways nice and open so that our patients don't have to work so hard with each breath, which can move them towards respiratory failure. If your high flow is effective, you should be able to notice fairly quickly that it's working through the reduction in your respiratory rate, a decrease in your work of breathing, so things like tripoding with your pediatrics. Are they retracting? Are they nasal flaring? Or has that been resolved? Or how severe are the retractions now? Or where are the retractions now? We should see a decrease in our CO2, whether it be through an ABG or capnography, depending on what setting that they're in. And then we should also see an increase in your ventilation and gas exchange, which goes back to that decrease in CO2, but we're also looking at the SpO2, and if a blood gas is given in a very rare occasion, then the PaO2 should also be increased. Another great opportunity for high flow is the decreased opportunity for infection. It reduces risk of reintubation. It reduces risk of pneumonia. It decreases suctioning requirements, and it decreases time for decannulation for tracheostomy patients. If we're reducing the risk of reintubation, if you've just pulled that tube out and you're worried about if this patient is going to fly or not fly, then we can use high flow to try to give them that little bit extra boost and meet their respiratory demands so that we don't have to worry significantly about them going back into respiratory failure. And if we can keep them from being reintubated and ending up back onto the ventilator, we're therefore going to be reducing the chances for them to contract ventilator-associated pneumonia, or VAP. It reduces the risk of pneumonia even for our non-ventilated patients. For our patients that have those thick, tenacious secretions, by giving them this high flow and allowing those secretions to be mobilized and not to fester in those lower airways like it so often likes to do with some of our chronic patients, if we're able to keep them moving, we're going to decrease the occurrence for pneumonia to occur. It's going to also decrease our suctioning requirements. Now, this is especially true for our tracheostomy patients with their thick secretions that we just can't seem to manage. We suction and we suction and we suction, but it just keeps on coming and they're just so thick and we just can't get them up and they're mucus plugging, and it just never seems like we can suction them enough. By applying the high flow with humidified gas, we can reduce the suctioning that's required because we're thinning those secretions and we're mobilizing those secretions more effectively. And we'll go into more detail about why it is that we're able to decrease those suctioning requirements. And it also can decrease time for decannulation for our tracheostomy patients. So if we have a tracheostomy patient who is on trach collar with humidified high flow, their secretions are being managed, we're able to see how well they're tolerating it, we're able to get the secretions under control and at bay and see if they're able to manage it themselves, we're able to see how well they're oxygenating. Again, we can pair it with that speaking valve or even have them capped with the high flow. And so it can decrease how long they have that tracheostomy. If we can get that tracheostomy out of them in a timely manner, that's going to reduce the opportunity for infection, because anytime we have a way for bacteria or microbes to enter our body, and the tracheostomy is a prime opportunity for bacteria to get into those bodies, if we can decrease the time that they have that opening and that opportunity, we're going to decrease the opportunity for infection for these patients. There's multiple interfaces. There's interfaces available for a variety of patients. For our invasive patients, we have the direct connect, and we also have a trach mask. For our non-invasive patients, we have the nasal cannula. For the direct connect for our invasive patients, and this is the picture at the top left, the one that's connected directly to the trach tube. So what this does is, since it connects directly to the trach, they are getting all of the flow available. They are able to get all of the humidification available without worrying about that extra space for it to get free or lost, or that humidification being lost, or that oxygenation becoming variable because they have that bulkier trach mask. It makes sure that it's all right there, and it's also going to ensure that they're getting that dynamic airway pressure as well, like we discussed before, which reduces your dead space and increases your alveolar ventilation. Now, you do have the option of the trach mask, which is shown on that picture of the baby at the bottom. As you can see, there is definitely a time and place for the trach mask, but it's not really ideal for our pediatric patients, especially our babies, because they don't have any neck. So anytime they move or they squirm and it moves and it's irritating their skin, it can be really difficult to make sure that they're actually getting the flow and the humidification that they're needing. Now, for some trach patients, it works really well if they're not really needing that additional support, but they're more so needing the humidification. It can work well for them. But it's important to note that it's likely that they're not really going to be delivered the exact same flow that you are setting on your high flow. For our non-invasive patients, we have the nasal cannula. So most of these cannulas, with the exception of the high velocity cannulas, are a whole lot wider than your typical binasal cannula, so that when it sits in your nair, it's going to be taking up more space in there, so that there's not going to be as much loss of pressure, and it's going to make sure that that flow is being completely delivered. And there's a lot of chronic patients who are able to go home with a high flow nasal cannula if they're needing more of a boost than their typical binasal cannula. It's just not meeting their inspiratory demands, but they're not really qualifying for non-invasive ventilation, or they don't want to wear non-invasive ventilation all of the time or at night. It's a great opportunity for them to wear the high flow instead of a big bulky mask, or worrying about if they're going to tire out with the binasal cannula. Now let's dig into the 100% relative humidity. 100% humidity is equal to 37 degrees Celsius. It increases the number of mucociliary beats per minute. It increases secretion mobilization and management. It significantly improves compared to 97% relative humidity. It improves comfort and has effects several hours after removal. When we're talking about 100% humidity with our high flow, we are talking about making sure that that humidification is reaching 37 degrees Celsius. And this should sound familiar because that's the temperature of our bodies. And that's the point. What we're wanting to do is make sure that the gas and the humidification that's being applied to our patients is matching the temperature of the bodies. And so it's going to not have to worry about bypassing all of our natural humidification routes. So especially with our tracheostomy patients, we know with our tracheostomy patients, they're not using their nose or their mouth. They're breathing straight through to their trachea. And so the natural humidification you and I get by breathing through our nose and mouth, they don't get that. So if we're not matching that humidification, we're putting in something colder. That's going to increase the viscosity of secretions, which is going to increase the likelihood of mucus plugging. And it's also going to decrease the overall mobilization of secretions. And that specifically relates to the number of mucociliary beats per minute. So as we know, our airways are lined with these cilia, and they wave around like this. And they're used to push secretions and foreign materials up and out so it can be coughed up. Now, when we have 37 degrees applied to our humidification, it's going to significantly increase how many waves that cilia has. So if we are putting them on, say, 34 degrees Celsius, the number of beats per minute are going to be a whole lot slower because it's colder. They're not as well lubricated. So they're trying, but it's just not enough. Whereas when we reach 100% humidity, they're nice and hydrated, and they're able to move as much as they want, and they're able to push those secretions out at a faster rate so that then they can be coughed up. And even with 97% relative humidity, the difference between that 3% is significant. And there's a video after this slide that compares and contrasts 100% humidity to something lower, and you can see just how quickly those particles are moving. Now, something that's important to note about this increase of mucus mobility. A lot of times when we start our tracheostomy patients on high humidification, this 100% humidification, they'll put it on and caregivers will say, oh my gosh, I've never suctioned them this much before, it's making them worse. So we just have to explain to caregivers or nurses, other respiratory therapists that no, this is exactly what it's supposed to do. Because all of this junk, all of this mucus and secretions that have been just stuck in your patient's airways, now the cilia are actually able to move it up and out. So it's all of this extra gunk that's been sitting there for who knows how long. Now it's coming up. So for that first week or two, it's likely that they're going to have to suction their patients or their family member a whole lot more often as that old stuff comes up and out. But once we get the old stuff out, then the rest of their secretions from then on should be well managed to where we don't have to suction them as frequently. And it's also going to improve comfort. If you add cold gas into your airways or to your nose, have you ever been outside, or are you one of those people that gets nosebleeds in the winter because you have all of that cold air drying you out and you get the nosebleeds and they're dry and you wake up in the morning and it's just like caked? Imagine if you've got that cold air being pumped directly into your airways. That's going to be really uncomfortable, and you're going to have patients that are more prone to nosebleeds, and they're not going to want to be compliant because it dries them out so bad. And on top of that, going back to the secretion management, they've got all of these secretions building up and they feel so congested and gross, they just don't want to deal with it anymore. So by providing that 100% relative humidity, it's going to make sure that the airways are nice and humidified and hydrated so that they're comfortable and they're going to be able to keep it on for as long as they need. And this 100% relative humidity is able to have effects for several hours after it's removed from your patient. So a lot of times I'll suggest to family members with tracheostomy family members that so they've got really thick secretions and we're trying to, but they're on an HME during the day, but when they wake up in the morning, I feel like I have to suction them a whole lot and it's just so thick. You can place a patient on the high flow 100% relative humidity just during sleeping hours, and it's going to still hydrate the cilia as it needs to be so that throughout the day it's still going to be mobilizing their secretions, even if they have an HME in place or they're capped or they have a speaking valve in place. And that's another benefit of the 100% relative humidity with 37 degrees Celsius. Touching briefly on traditional cool mist aerosol. Provides bland aerosol at cooler temperatures, improves comfort to inflamed airways, provides moisture to bypassed airways, can provide support to your work of breathing. It's indicated for upper airway edema, post-op management, mild secretion management, and some precautions are higher risk of infection. Cool mist aerosol is typically when you have one of those big, large volume nebulizers that you hook up straight to the tube and you hook it up straight to the trach mask or the face tent or the aerosol mask. And it just provides this nice, cool mist. And it's useful if you've got inflamed airways or someone's just got out of post-op and they've just been extubated and their throats are just so raw and they're uncomfortable. It can provide some comfort to them and help re-moisturize those airways. Or if you do have a tracheostomy patient, for short-term, cool mist aerosol could be beneficial. And it can provide support for work of breathing. It's not the most effective way because it's not necessarily going to be providing the flow that they necessarily need, or it's not going to assist with the secretion management, which can take up more space in the airway, and so that flow isn't really reaching where it needs to go anyway. The indications of upper airway edema, often with, say, like our croupy kids, our post-extubations, post-op management, and it can provide that mild secretion management, but if you have that really thick, those thick secretions, I know I'm saying thick secretions a lot, but it's a big part of this. If it's just mild and they're a little bit junky, you can provide a little bit of cool mist just to hydrate those secretions enough to loosen them up and be able to cough it out. But a precaution is that there can be a higher risk of infection because you have higher amounts of rainout, amounts of water that is dropping down into the circuits and can be aspirated, or those water droplets that can carry bacteria are more apt to enter the airway and cause an infection. Some of the precautions for our high flow and humidification. Be aware of rainout. Position the tubing appropriately. Be aware of infection risk and change in FiO2. Titrate according to the patient's needs and overhydration. So, rainout is one of the biggest things that we want to be wary of when we're applying high flow and 100% relative humidity to our patients. So what happens with rainout is that as the gas is moving from the device to the patient and it cools, it can rain out and drop into the tubing and to where it's sloshing around, or depending on how your tubing's positioned, it can splash your patient in the face. So one of the things when we're thinking about rain out is making sure that we're positioning our tubing appropriately, especially for our tracheostomy patients, but of course for all of our patients. We want to make sure that we're not keeping that tubing up too high to where the water is going to fall down and into the patient's airway, whether it be through the nares or the tracheostomy. We want to make sure that the tubing is positioned so where it's going to flow away from the patient. And if you're able to use one of the water traps in the middle of the circuit so that the water can fall into that bag, that's fantastic. It's a faster way to be able to deposit that extra water into that bag. You have to be aware of infection risk with rain out because, again, water is a great opportunity for little joyride for bacteria to take. So if you have large amounts of water in your tubing that isn't being managed and it's sitting still, it's an opportunity for bacteria to harbor in there, and then it's going to spread throughout your circuit and eventually infect your patient. Also with rain out, you can have a change in your FiO2. The more rain out you have, the more water that's taking up that space in that tubing can cause your FiO2 to actually increase because we're reducing that space, and the flow that's being delivered is going to be higher in the oxygen than it is with your air. And so with our COPD patients or patients we want to be aware of hyperoxygenation, we want to be able to know that, okay, their tubing is filling up with water. How much oxygen are they actually applying? Or, oh, it's time that we need to dump this out so that we make sure that they're not being hyperoxygenated. With high flow, you also want to make sure you're titrating according to the patient's needs. Yes, there are different protocols a lot of facilities have for weaning, but you always want to watch your patient, see how your patient is doing. Are they able to, is being weaned 10 liters too much for them? Can we do 5 liters? How's their oxygen? Do we need to do the oxygen and not the flow? Always look towards your patient's needs, their vitals, how they're looking, how they say they feel. They're all super important with managing their high flow. And we also want to be aware of overhydration with humidification. Again, we're applying moisture into our patients' airways. So it is possible for them to become overhydrated. With neonatals, this is especially significant. They can be very prone to overhydration and then having issues with their cellular function. Now we're going to do a knowledge check. So our first question. A tracheostomy patient has been receiving heated high flow, but his nurses state that his secretions have remained thick and that he's been experienced multiple mucus plugs in the past week. When you observe the patient and the device, you see that the flow is at 45 liters per minute, 21% FiO2, and 34 degrees Celsius. What is your first recommendation for resolution? Increase temperature to 37 degrees Celsius. Remember that 37 degrees Celsius is that magic number to reach 100% relative humidity, which is so crucial for our tracheostomy patients. Remember, it's going to help those cilia dance a little bit more and increase the mobility so that those secretions can move more effectively to move out and be suctioned more effectively. And you also want to make sure that you're monitoring secretion change. Monitoring, okay, are we having changes in color, in viscosity? How long are we having, how many times are we having to suction them now? Just keeping really good documentation and being aware of how their secretions are changing throughout the course of this temperature change. And also the monitoring of rain out. Because we're increasing the temperature that's being delivered from the device, it has a higher opportunity for it to cool and rain out. So we always want to make sure that we're monitoring our rain out to prevent any issues with aspiration or infection. Number 2, a COPD patient on your unit has begun to show signs of respiratory distress with a respiratory rate of 36, SpO2 of 78% on 2 liters per minute by nasal cannula, heart rate of 152 beats per minute, and an ABG showing CO2 of 56 centimeters of water. Physicians are considering beginning non-invasive, but the patient is claustrophobic and refusing a mask. The care team is concerned that the patient will soon reach respiratory failure due to the increasing CO2 and respiratory rate, but are trying to prevent intubation. What is your recommendation? High-flow nasal cannula provides adequate flow to meet or exceed the patient's respiratory demands. If they're breathing fast and their CO2 is creeping up, they're needing some support. They're not able to meet the demands on their own. They're trying with that elevated respiratory rate, but they just can't get the flow that they need. So that's where high flow can come in. You can still apply your FiO2 to get them where they need to go for their SpO2, but you can also adjust it independently of your flow. This is especially significant for our COPD patients because we don't want to hyperoxygenate them and run that risk of overriding their hypoxic drive. And also it can provide that CO2 washout. Their CO2 was a little bit elevated, so by increasing that pressure, elongating that exhalation, we're going to be able to get more of that CO2 out. And we can also consider, of course, the high velocity nasal insufflation. We can have even higher amounts of CO2 washout, but because it's that high velocity, remember it's being delivered faster than, say, your conventional high flow, you can have lower flows to have the same effect. Number 3, a tracheostomy patient is being liberated for mechanical ventilation and is taking spontaneous breaths, but physicians are concerned about the patient's oxygenation needs and risk for atelectasis. Some physicians are discussing invasive CPAP at 5 centimeters of water. Why would you not recommend this, and what would you recommend instead? Invasive CPAP is not recommended due to the risk of pneumonia and mucus plugs. That constant pressure is going to prevent the mobilization of secretions to the upper airways. Like we mentioned before, with that constant pressure being pushed down, and it's not as dynamic because it's being provided by the ventilator and not as dependent on the patient's breath, it's more likely to produce those mucus plugs, and it's going to harbor bacteria and it can thicken and cause pneumonia. Instead, we can recommend high molecular heated humidification. We can use a direct connect if it's available to make sure that we're providing that 0.5 to 1 centimeters of water of PEEP per 10 liters. And the heated humidification can allow for secretion management. And also, it's going to be a whole lot more comfortable for the patient and for his future caregivers to manage a high flow as opposed to a CPAP, which is typically going to be through some sort of ventilator. A COPD patient is on high-flow nasal cannula at 40 liters and 50%. The nurse states that she has noticed that the patient's respiratory rate has increased from 14 breaths per minute to 22 and asks you to evaluate him along with the recommendation of increasing the FiO2. Upon evaluation, the patient's SpO2 is 96%, heart rate 130 beats per minute, and respiratory rate of 22 with noticeable labored breathing. What actions do you complete? Maintain or lower the FiO2. This patient's SpO2 is in satisfactory limits. We don't necessarily have to lower it right now because they are in distress, so we don't necessarily have to touch it, but we could if we're trying to move them, wean them from the oxygen. And COPD patients often have a lower SpO2 at baseline anyways. But what we will do is increase the flow to decrease the work of breathing by meeting or exceeding the demands of the patient's having, as shown through the increased respiratory rate and the labored breathing. And then we also want to make sure that we're monitoring our patient to make sure that it's effective. Do we need to increase it more? Is it too much and now they're fighting against it? So it's always important to monitor your patient following any changes that you make to your high flow. Number 5, a tracheostomy patient has just entered the facility and is placed on 20 liters per minute cool mist bland aerosol via large volume nebulizer and trach mask. Why or why not is this a preferable form of humidification for long term? It is not preferred. We're already bypassing the body's natural humidification system because our patient has a tracheostomy, so they're not using their nose or their mouth. It's going to increase the risk of thickening secretions because, again, they're not getting any heat because they're not using their humidification system. So we really need to provide it. We need to supplement that humidification that they're not being provided naturally. It's also not being preferred because it does increase the risk of infection, especially with our tracheostomy patients. Because of those water molecules like we talked about are more likely to harbor bacteria, and it's going directly into the trach, this can significantly increase that risk of infection and pneumonia or tracheitis. It can be suitable for short term, say they just got transported, but we should not rely on it for a long-term modality. Instead, we should make sure that we're using that 100% relative humidity. I want to thank you for joining me on this module of high flow therapy and high velocity nasal insufflation. Again, my name's Jacqueline, registered respiratory therapist and neonatal pediatric specialist, and thank you for joining me.